evening. My name is Julian Espinoza. I'm privileged to be here with you today. It wasn't but about 4 years ago that I was sitting in these seats as a Foundations to Medicine student, and now just graduated from St. George's, and it's a privilege to be with the professors who made that possible, as well as the students, and that energy that I feel here was the same as it was a couple of years ago. But we're here tonight to listen and learn and honor a man who is really a humanitarian, a trailblazer in medicine, and really what you would call medical royalty. I actually, by sort of a strange chain of events, came to know about an invention that Dr. Jeffrey Ponsky made. I'll tell you about it in just a moment. Before I started clinical medicine, you probably know that you're in basic sciences, but you really don't know much about how the rest of the world works. And I was talking with Jonathan Modica's sister-in-law, who's a nutritionist, and this was before I ever started clinical training, and I asked her, as a nutritionist, what advice could you give me in terms of treating my patients that you think was potentially life-saving or life-altering? And she said, the best advice I could give you is, if you have a cancer patient that you're going to put through a lot of chemotherapy, make sure they get a PEG tube. And I didn't know what a PEG tube was at that point, but basically it's a feeding tube, a percutaneous endoscopic gastrostomy tube that enables you to put a feeding tube in without having the patient have to actually ingest food. As we know, you get chemotherapy, causes you to puke your guts out, you don't feel like eating, anorexia, cachexia, and then you ultimately die. But with this feeding tube, you can get through you can get through that position and maybe not just extend life, but save your life. And then it was about a year later where I met a patient. His name is Mr. David Cohn, and he passed away from metastatic recurrent cancer. As you can tell, he was made quite an impression on me. But the most important thing about David was that he was a fighter, and he challenged me. Every time we wanted to do an intervention on him, he would challenge us, and he said to me, as far as why the feeding tube, and we argued a lot about it, and he eventually decided to have the procedure that Dr. Ponsky invented, and as a result, it prolonged his life for about 8 months. And his parents, when he died, said, you know, you gave him hope by telling him to get that feeding tube, and we had such a great quality of life with him for those last 8 years. And Dr. Ponsky invented this out of necessity. But not only that, in terms of medical innovation, he's committed to medical education. He's published over 200 articles, textbooks, and he's also deeply committed to our education here at SGU, and that's why he's here. He's trying to figure out a way to work with his family, the Ponskys, his sons, who are also surgeons, to enable us to not only score better on our boards, get better residencies, but be better physicians. And they're not only educators and surgeons, but they're also philanthropists. And we just, thanks to them, sent a container of very large container to South Sudan full of medical supplies, mannequins, training devices, and the first laparoscopic surgical suite ever to reach the country of South Sudan, thanks to MedWish and the Ponsky family. So it's with great privilege and respect that I get to introduce this wonderful physician, Dr. Ponsky. Oh, and by the way, he didn't patent his invention, so that's another reason why he's my hero.
Another thing. Thank you. Is this too loud? You can hear me all right? Okay. So I'm going to talk to you today about peptic ulcer disease. I know you all came at 6 o'clock at night to hear about peptic ulcer disease. And this is a lecture that I've been giving for more years than many of you have been alive. And you might ask, why the heck would I want to give a diverse audience a lecture in peptic ulcer disease? Because what I tell people is it has nothing to do with peptic ulcer disease. Or we'll talk about peptic ulcer disease. But this is really about your life. This is about your life. This is about your education and about your life. So let's think about that for a minute. You guys go to medical school here? Do you pay money to go to medical school? All over the world, people pay money to go to medical school. It costs a lot of money to go to medical school, doesn't it? Yeah. So if it costs a lot of money to go to medical school, you'd expect Modic and these guys here to be teaching you the truth. I mean, if they're not teaching you the truth, you just graduated. You got to take your board. You hope they taught you the truth, right? So you think you're the first guys that wanted the truth? You know, back in 400 BC, that was before I was born, 400 BC, there was a guy named Plato. Not Play-Doh, Plato. Any of you ever heard of Plato? Yeah. And Plato, he didn't have, like, the internet. Mark, there was no internet. He went whole days without the internet. And they didn't have TV, so he sat around and he just looked at the stars and he thought about the meaning of life and truth. He was really into what was truth. And so he wrote a little parable that some of you may have read in college called The Allegory of the Cave. Did you ever hear that story? No, you cheated that day. The Allegory of the Cave. So what's the story of the Allegory of the Cave? Well, the story is that there's a whole race of people that are in a cave, and they sit next to each other. I'm a terrible artist. They sit next to each other, and they're bound hand and foot, and all they can do is look at the wall, and their captors build a fire behind them, and they hold up things like a branch, like this, and it casts a shadow on the wall of the cave. And those people can only look in front of them at the wall of the cave and see the shadows flickering from the fire behind them. And they develop a whole hierarchy of who's important. Because the people who could recognize those branches, those images faster, are the smartest, and they can see the real truth. And so there's a pecking order that develops, a hierarchy. And then Plato says, imagine that one day the captors free a single captive, take him out of the darkness of the cave and up to the light of day. And at first the light blinds his eyes, it hurts. But then his eyes accommodate, and he sees a real branch, a real tree, in full color. He's amazed. He rushes down into the darkness of the cave to tell his fellow captives, I've seen the real truth. And what do they say to him? You're crazy. You're a heretic. You're nuts. That's the real truth. The point of the parable is that the truth is often based on what we can perceive it with. If we have tools, new tools to perceive it, then our idea of what the truth is changes. And so, 100 years ago, if I would have told you that there was music playing in this room right now, Pandora is going on in this room right now. You can hear Kenny Rogers, Willie Nelson, whoever, Frank Sinatra, it's all in this room right now. 100 years ago, they would have put me away for that. But all of you know that that's absolutely true, if you can get Firefly in here. Because you know that if you can get the internet, those songs are here. But you don't see them, because you don't have the tool with your eye to see that. But now you say, well, of course, there's radio waves, we know about that. No big surprise. So the truth changes based on what tools we have to perceive it with, and how we put old information together with new information. So now I'm going to tell you the story of a medical problem. And I want you to listen to this problem, because we think that we're teaching medicine at a state of the art we've never seen it before. That we're teaching you right now, you're reading that book about inflammation, we're teaching you state of the art truth right now. So ask yourself, 120 years ago, when William Halsted was at Hopkins and William Osler was at Hopkins, What did they teach medical students for 4 years? They didn't know about the Krebs cycle. Sorry. They didn't know about the cytochrome system. They didn't have blood transfusion or blood typing. They didn't have antibiotics. They had no pharmacology. They had leeches. So what did they possibly spend 4 years on in medical school? What do you think? What did they teach? Anatomy. Where did they get the bodies? They were dead. They stole the bodies. They dug them up in cemeteries after executions, in Potter's Field where poor people were buried, and they stole the bodies and took them to the medical school. It was illegal. And they studied anatomy. And did they know anatomy well? Yes. To a degree that you'll never know it. They knew they would hold a skull in their hand like Hamlet, and they would know every foramen by name. And they would tell you, yes, the stylomastoid foramen, the facial nerve goes through there. And then it branches. They knew every detail of anatomy because they had not anything else, and they studied it and studied. They also knew bandaging very well. If you look at the pictures after the Civil War, they were really good at bandaging. You guys know how to bandage? Maybe a Band-Aid, but that's it. Okay, so that's what they did. They studied. So let's put ourselves back to about 1889, and let's go to Johns Hopkins, and imagine that we have William Osler, the father of modern medicine. He was wonderful, greatest teacher. And Osler's sitting there at Hopkins, chief of medicine, with a patient who has terrible pain in his belly. And he knows that this pain is relieved by eating, and he diagnoses this to be peptic ulcer disease. So what caused peptic ulcer disease? What did they think caused peptic ulcer disease in those days? What causes peptic ulcer disease today? You don't know that yet. Gastric acid was the truth then. Gastric acid was absolutely the truth. What causes peptic ulcer disease, Doc? H. pylori. In 1990, they discovered H. pylori. They said it was the greatest thing since the discovery of the cure for polio. I'm not sure that's true. But H. pylori, this little bacteria that lives in the lining of the stomach, we know now that it blocks the production of PGE3, prostaglandin E3, and the mucosal barrier is destroyed, and acid diffuses causes ulcers. But they didn't know that then. They knew it was acid. And so here he is struggling with this, and he calls up his buddy. I don't even know if they had a telephone then. They sent a student up. Go get Halsted. Go get William Halsted, the father of modern surgery, and tell him we got a patient for him because we have to treat this ulcer disease. Now here was Halsted, you understand. There's a new movie out called The Nick. Have any of you seen this thing? It's a video. I don't know what channel it's on. It's so good. It's the story of Halsted. Halsted wasn't always on time because he was doing cocaine. Now here is the greatest surgeon of his time, and he's doing cocaine. You'd think that they'd pick a better guy to be the chief of surgery at Hopkins. This is, where is it? That's your school. So what happened? Why was he doing cocaine? Everything has to be evaluated with perspective. Why was he doing cocaine? Because anesthesia in 1880 was brand new. Morton had just discovered drip ether, but they were trying local anesthesia by injecting it. And what was a good local anesthetic? Cocaine. And how did doctors practice in those days? They would experiment on themselves. He didn't know he was going to get addicted, and a lot of others did too. So you can't blame Halsted from here looking back. Oh, I would never do that. He was a genius, he was a brilliant man, but he became addicted and suffered the ravages of cocaine addiction. So here goes Osler up to see Halsted and says, Bill, help me out. I got this guy, he keeps coming back. He's a big donor to the hospital. I got to help this guy. So Halsted says, what causes acid? What causes ulcers? Acid causes ulcers. So what could they do with short duration anesthesia? Oh, by the way, no respirators, no IV antibiotics. no IVs, no intensive care units. They had to sort of operate quickly. So he says, okay, let's take care of that acid that was in the stomach. Let's get rid of it. So what was a quick operation they could do? They would take the stomach here. I hope you recognize this from anatomy. That's the stomach. They would take the stomach and they would sew it to the small intestine, the jejunum, like that. That's called a gastrojejunostomy. And that was the first operation, hydrogen, acid, the first operation ever done for ulcer disease, a gastrojejunostomy. Just get the acid out of there fast. It seemed logical. But guess what? It didn't work. It didn't work, but they developed new ulcers here in the small bowel called marginal ulcers because that bowel was not buffered or ready for the acid. And so that was a failure, that operation. Had a 50% recurrence rate. And so we'll put that on the board over here as the first operation, gastrojejunostomy. And it was a failure, but it was based on the truth of the time. And the truth of the time was anatomy, wasn't it? The truth of the time was anatomy, and that's all they had to go on. So they did an anatomic operation. So then they said, well, you got to do better. Osler says to Halsted, you got to do better. And so Halsted thinks about it. He says, well, I can still do an anatomic operation because in those days, Bill Roth and others were starting to do operations for gastric cancer where they took out almost the entire stomach. It's a little radical for peptic ulcer disease, but they took out almost the entire stomach. And so the next thing based on anatomy that he did, since the stomach made acid, they would take out 80% of the stomach like this. 80% of the stomach. They would oversew the intestine here, the duodenum, and bring this up like this. That's called a subtotal gastrectomy. Subtotal gastrectomy. Do you think that operation prevented ulcers? It's pretty early in the lecture. The answer is it did. That operation had a 99% success rate in preventing ulcers because it took out the organ that produced ulcers, the stomach. The parietal cells produced it, and that was in the stomach. So that operation was called subtotal gastrectomy. So let's talk about that. Could be the end of the story. Except that this had a high mortality. At a time when we had no intensive care units, had no IV fluids, had no antibiotics, these patients died in large numbers. Okay, we understand that. What else? We found that if they did survive, if you took a middle-aged female who was started out being a little bit thin, many of them wouldn't even be able to eat enough to sustain their life after the operation. They had malnutrition and died, called inanition. So that was a bad thing. Another thing about the operation is that about 15% of them, after the operation, had horrible, horrible symptoms of what we call dumping. Now, what is dumping? There were two types. About 20 minutes after the operation, up to 2 hours, some patient would get terrible cramps, sweat, their blood pressure would drop, and they would get diarrhea. And what they thought, they called it dumping because they thought all of this hypertonic fluid would be dumped into the small bowel. But they found out later that this was not due to the hypertonic fluid, that this was a new thing that they hadn't seen before. It was due to a hormone called vasoactive intestinal polypeptide. First they tried other hormones, and I won't bore you with them, kallikrein, etc. But this was VIP, vasoactive intestinal polypeptide, and so a whole new area of GI endocrinology, all peptide hormones, suddenly became apparent. And there was an inappropriate release of this VIP from the pancreas. And these patients got this dumping syndrome. Other patients got the same symptoms, diarrhea, cramps, tachycardia, and hypotension 2 hours to 4 hours later. Why did they get it later? Well, it was discovered later that when you normally eat, food goes into your intestine here, and your intestine is an endocrine organ. Your intestine puts out a hormone called GIP, gastric inhibitory polypeptide. What do I know about that? It's a polypeptide. What it does is it goes to the pancreas, to the islet cells, which are an endocrine organ, and it tells them to put out insulin. The problem in these patients is that the amount of insulin is not in proportion with the amount of sugar absorbed. So at the end of 2 to 4 hours, there's excess insulin in the bloodstream, and these patients get what we call insulin shock. Insulin shock lowers your blood sugar, lowers your blood pressure, and raises your heart rate. That's what late dumping is due to, an imbalance between the amount of insulin released and the amount of sugar absorbed. So this was a whole new field, but it was a complication of the operation, these dumping things. So this operation was put on the shelf for the most part. Patients died from it. Patients died because they couldn't maintain their weight. And suddenly we had this new complication of dumping that was really a problem. So we put it on the shelf. Now I'm going to step over here and tell you that somebody opened the history books 100 years later and said, you know, some of those women lost a lot of weight. Look at that. If I take out 80% of the stomach, what if the patient is real fat before I start? What do we have then? A gastric bypass. And so the whole field of bariatric surgery for morbid obesity was born out of a mistake. That people started to say, wait a minute, if I use that operation as a basis for a bariatric operation in the morbidly obese, I may have something, and that is still what it looks like today. So that old mistake was taken off the shelf, and we learned from it. But it didn't cure all of peptic ulcer disease. So people said, enough of these surgeons. These surgeons are just basing everything on anatomy. That's not the real truth. We learned about endocrinology now. And there are other things being discovered at the same time. There was this guy named Pavlov. Did you study him in psychology? He rang bells for dogs. And he discovered the phases of digestion. Did you memorize those phases of digestion when you're in psychology class? You know, I always tell people when I go outside in the spring, my son Lee's here, remembers, we go see the hot dog vendor. And we go by the hot dog vendor on the street. If you had to walk by it, you'd smell that hot dog, wouldn't you? What happened then? You start to salivate, right? And your stomach starts to grumble. What causes that? The picture of the hot dog goes up to the cerebrum, takes a picture of the hot dog, it goes down to the area postrema of the fourth ventricle. How do you like that for remembering anatomy? Okay? And that fires off the vagal nucleus, which causes your mouth to salivate and the enzymes to go there, right? And your stomach starts to churn and produce acid. That's the first phase of digestion, and that is called the cephalic phase. Perfect. So the cephalic phase by Pavlov was the first phase. And we know that the cephalic phase was mediated by the vagus nerve. So then I go and I buy the hot dog. And I eat that hot dog and I chew it up in my mouth. And the salivary enzymes help destroy it a little bit, break it down into smaller protein fragments called peptones. And those smaller fragments go into my stomach and it distends the stomach. So suddenly the food distends the stomach and the food buffers the acid that's in there from the cephalic phase, so the pH rises, right? And those peptones stimulate a number of cells in the antrum called the G cells. All of that together causes a secretion of a new hormone called gastrin. And gastrin I love this word, is a heptadecapeptide, 17 amino acids, and it goes back through the bloodstream to the parietal cells, the H2 site on the parietal cells, and causes acid to be secreted. That is the gastric phase of digestion. So we say that the second phase of digestion is the gastric phase, and that is mediated by gastrin. Okay. And what is this? This is endocrinology and physiology. So suddenly now there's a new truth in town. Suddenly now there's a third phase called the intestinal phase, which I won't go in right now. But those two phases were the basis of a new type of surgery. A fellow in Minnesota called Lester Dragstead said, I am going to base my surgery on new principles, the principles of physiology and endocrinology. And so I'm going to design an operation to ablate what? The cephalic phase. How would you ablate the cephalic phase? Which nerve? Exactly. So what he did is he said, good, we're going to cut this vagus nerve. Boom, boom. There's two right there. Now, they don't just exist in space. There's two vagus nerves. They come down the anterior, which was the left, and the posterior, which is the right, and they go like this. And this is called the celiac branch, and this is called the hepatic branch, and it goes all the way on the stomach. But he cut them up here. Those are called Truncalvagotomy. But what happened when he cut those nerves? The stomach became like a wet bag. It wouldn't empty. Patients started vomiting. They couldn't do that. So he had to go back and figure out a way to get the stomach to empty. So he said, you know what? We had that first operation, gastroenterology, that emptied the stomach. We could do that. So truncalvagotomy and gastroenterology, or we could just take the stomach like this and we could destroy the pylorus, like the little kids have with their fortune-telling game. We destroy the pylorus and sew it back together like that and do the truncalvagotomy with that. And so truncalvagotomy and pyloroplasty, or truncalvagotomy and gastroenterostomy, or what we call truncalvagotomy and drainage, became the panacea operation, the real truth. That was it. For 2 or 3 decades, from the 50s through the late 70s, this was the operation, and it's still used today. Truncalvagotomy and drainage. So we'll put that down. Now, this operation was easy to do, had a low morbidity, low mortality, and it had a 15% recurrence rate. Now, 15% recurrence isn't bad. What were the complications of this operation? This operation, some people got terrible diarrhea. And the diarrhea was for denervating the bowel, the vagal part of the bowel, the celiac plexus. Some people got gallstones because we denervated the liver. And 15% of them also got dumping, like before, because the pylorus was either bypassed or destroyed. So what? You know, I'm the surgeon, you know what I tell you? Everything has complications. I just cured your ulcer disease, but there's still complications. But 15% recurrence rate, you know, in medicine, what do we like? The 95% confidence interval, right? We want a p-value of 0.05. You remember, memorize that. So how can we make this better? How can we make this operation better than 15% recurrence rate? What else could you do? You could get rid of the gastric phase too, couldn't you? So how would you get rid of the gastric phase? Got to get rid of gastrin. Where's the gastrin made? In the antrum, because that's where the G cells are. Okay, so we'll take out less of the stomach. We'll go over here and just take out the lower 40%, like that. And now we have another operation. And this operation is based on physiology and endocrinology, and that's called an antrectomy and truncalvagotomy. The truncalvagotomy for the cephalic phase and the antrectomy for the gastric phase. Now you have to hook them back together. You can either do it like that, and that's called a Billroth 1. and this isn't really important, or a Bill Roth 2 where we go like this. That's just how you hook it back together. So did that operation work? That operation worked. Had a 98% cure rate, 2% recurrence rate, truncalvagotomy and drainage. Truncalvagotomy and antrectomy. Had a 2% recurrence rate. However, 15% of the people still had dumping, and some people still had that terrible diarrhea. But we figured, well, that's just too bad. That's a problem with the disease. But then somebody got interested in history. Somebody went into their grandfather's locker, pulled out something called a book. That's not a book. Something called a book, opened up the book, blew it off. It was an anatomy book. And he looked at it. And lo and behold, this book had these picture of the stomach, but these yellow lines coming down on the stomach. Do any of you know what the yellow lines are? Huh? No? On the outside of the stomach? What's an anatomy book? What's the yellow lines? You haven't seen one in a long time. Those are the nerves. They paint nerves in yellow. Blood vessels, arteries are red, veins are blue, and nerves are yellow. And they looked at that. And this guy looks at the pictures of this nerve, the vagus nerve, and he looked at it, and he said, wow, when I cut these truncal branches, it denervates everything. Kills the gallbladder, so you get gallstones. Denervates the gut, so you get diarrhea. And the stomach doesn't move anymore. So you need a pyloroplasty or drainage. So what if I just denervate the stomach? I just denervate the stomach by cutting all these branches, but I leave the celiac branch and the hepatic branch. And that was called a selective vagotomy. A selective vagotomy. So that was an advance. And that still had a 15% recurrence rate. On the other hand, these patients didn't have gallstones anymore, and they didn't have diarrhea. That helped. But they still had dumping because the pylorus was destroyed. Okay? So he started looking at the picture even further. And let's look at this picture. He looks at the stomach. He sees the vagal nerves coming down, the celiac branch, the hepatic branch, all these nerves which had names, and then the final nerve here, which looked like a crow's foot. And that nerve had a line by it and a name. That nerve was described by a French anatomist 100 years ago. It was called the nerve of Latarjet. The nerve of Latarjet. And he said, wait a second. If I just stimulate that nerve of Latarjet, just that bottom branch, that crow's foot, what will it do? What? Will it stimulate? No, it doesn't really, not much. What? It contracts the pylorus. It's the motor nerve. Can it make acid? Why? There's a reason it can't make acid. And the reason it can't make acid was known 120 years ago by the poor guys who only had anatomy, because it doesn't have any parietal cells, which are located in the body and the fundus, to stimulate. It can't make acid because there's no parietal cells where it stimulates. So now we devise an operation where we cut everything but that nerve. We cut up and we denervate the stomach except for that nerve. Now, the acid part of the stomach is denervated, doesn't make acid. Cephalic phase is gone. And this just makes motor function of the stomach. So that's called a highly selective vagotomy. And that is based on anatomy. But what kind of anatomy? Histology. So what we've done is come full cycle. We've come full cycle from where anatomy was important to where physiology and endocrinology were prominent, and we poo-pooed anatomy, and now somebody using old information, old truths, is finding a new way to use the old truths in combination with the new truths. And so when you study in medical school and you say, well, I don't need to know that anymore, that's old stuff. What is important? Is anatomy important? You better learn it if you want to make a contribution. Physiology, endocrinology, it all can be reworked and re-put together in a new way. And so I always tell the story about a monkey in a cage, and they put a banana hanging from a string, and they put a stick on the floor. You read about this in psychology. At first, the monkey will try to jump for the banana and can't get it. Eventually, looks at the stick, looks at the banana, looks at the stick, takes the stick, and hits the banana down. That's insight. So discovery favors the prepared mind. If you know where the parietal cells are and where they're not, and you know what that nerve does and where it is, you can design something new based on a lot of old information. And so it's all important to know. It's all important. The real truth keeps changing and keeps depending on the new information that you have. And so when I say to people at the end of the lecture, so when would you operate and what would you do if you were confronted with a patient who came to you with peptic ulcer disease? So the one thing that has never changed is the reasons that we even operate on peptic ulcer disease. Why would you operate on peptic ulcer disease? If you had an ulcer, would you want an operation? Hell no. Why would you want an operation? First thing you do is say, give me some medicine. Oh, check me for H. pylori, because that causes most of them. And then give me medicine to get rid of the acid, and you'll be cured 90% of the time. So why do surgeons ever even operate anymore on peptic ulcer disease? The same reasons we operated 120 years ago. Nobody wanted us to have cases. They tried to steal our cases by medical therapy, and rightly so. So you operate on peptic ulcer disease for the complications of peptic ulcer disease. What is that? Bleeding, hemorrhage. When it heals, it scars down, so that's obstruction, hemorrhage, obstruction, perforation, poof, patient comes in with peritonitis. And finally, intractability when it doesn't get better anymore. And those are the same complications we operate on for today. The difference today is, and I just discussed this with my son who's a surgeon, is we do different operations than even around the board. Because if I go in to operate on your stomach today, and if I do, if I have obstruction of your pylorus, and it's very narrow, right here it's strictured, narrow. Before, I would have done a pyloroplasty and a vagotomy. It's on the list. Or a highly selective vagotomy and pyloroplasty, because I had to relieve the obstruction. Today, I would relieve the obstruction, but the board of surgery answer has changed. In addition to that, would I do a vagotomy? It's appropriate, but vagotomy, you see, has side effects. So what else could I do? Treat the H. pylori and give you a proton pump inhibitor, which would allow you not to have a vagotomy. So things change even since a year ago when I started modifying the talk. So I want you to all recognize that the truth keeps changing. And after you graduate from medical school, you won't stop learning or thinking, I hope. And so what you'll do when you finish is put old information together with new information to come up with creative new approaches. That's the purpose of this talk, is to let you know that what you're learning is appropriate at this time, and your creativity and your insight will make the changes for the future. All right, thank you very much. Questions? Any questions? Yeah.
You've been the chief of surgery at a major university hospital, Case Western in Cleveland, and now you're at the Cleveland Clinic. What advice would you have for us as medical students in terms of what you look for in your residents and in your medical students?
So that's an interesting question. You know, the interview is always just a small part of the whole process of selecting people. What we want is people who, what's that Friday Night Lights? Bright eyes and full hearts. And I think that that's not a joke. I think that you want somebody who looks at you during the interview and has a desire in their heart. Their record speaks for themselves. They have to have passed their USMLE and have good letters of recommendation. Don't ask people to write you letters of recommendation if they're going to write you bad letters. I mean, hello, that's an intelligence test. And you'd be surprised how many people don't realize that. So make sure that the people that you ask to write your letters are pretty reliable. That's number two. But when you go to interview with someone, look them in the eye, look interested in what they're doing. You guys all do. I just gave you a lecture and you engaged me. Your eyes were on me and you participated. That's what we want. We want a partner in the education. You talk to the educators out here, there's nothing better than having a partner in the education. Somebody who looks at you and says, yes, come on, give it to me. I want it. Right? And you want to take a chance in your education, too. And you want somebody who's willing to take a chance. Let me tell you about students. I have a minute or two. Let me tell you about students. I always tell this story about students. You know, a lot of them, I give a lecture and I ask a question. And you want to see what these people do with the question. So some of them just sort of hide out. You know, they don't want to answer the question. So if I give you $1, let me say I give you $1. Pretty conservative. I want you to take that $1 and I want you to invest it safely as you can. That means you have to make some interest on it. What would you do? You didn't think this was an MBA, did you? What would you do with that $1? You have to make some money on it. What would you do? Huh? You put it in the bank in a savings account, right? Okay, and you'll make almost nothing on it. Tiny amount of interest, right? Now what if, that's what I said. Now if I give you the same $1 and I say I want the greatest interest on this, what would you give me back? What would you invest it in?
I'd trade it to Bill Gates for $1 million.
He'd trade it? Bill Gates ain't going to trade with you. What would you do with that $1? You got to come back with the greatest possible return. Stock market, lottery ticket, boom, right? What's the problem with that? It's a high risk, right? So that's the old story of risk and benefit ratio. Okay, so let's talk about that regarding your own education. If you're sitting in the room and I'm giving a lecture and we're trying to interact with each other, and I ask a question, what's the first phase of digestion? Somebody did give me the answer, but what if I give you that question and you go, I might know it, but I might not. I'm going to keep quiet and let somebody else answer that question. You don't participate. You figure, I'll remember it when they say it. You will remember tiny amounts of information because you had no investment in that answer. You'll forget most of what you hear. But if you raise your hand and I call on you and your heart starts beating and you start flushing and you get it wrong, you won't forget the right answer. If you get it right, you'll remember it because you were happy about it. There was an investment there. The risk was that you might be wrong and embarrassed. But the reward was great. And that's how it is. People, when they interview you, want to know that you're willing to invest in your own education. Give them a plan for your future. Give them a look at your vision for your future. Tell them what you want to do. You won't do it. Everybody wants to be a pediatric surgeon. Only a few are stupid enough to do it like you. I mean, but you know, tell them what you want. Tell them what your dreams are. Tell them you're going to be a participant. And they'll go into the room later on to evaluate you and say, this guy was so electric. He really can't, you know, I know his grades were just okay, but this guy, I want to work with this guy. I like him. That's what they want to hear. This isn't a time to be shy, okay? It's not time to be a jerk, but it's not a time to be shy. So get involved. This is your chance. The interview is important.